Hello, everyone. This is Ali Aminian, Associate Professor of Surgery at the Cleveland Clinic, and I'm presenting to you the selected bariatric studies in 2017 for the third IFSO Journal Club, which will be held on February 28th of this year. Overall, I think 2017 was a great year in bariatric surgery research. As you see in this graph, in the past decade, there has been a tremendous growth in bariatric literature over the years. In the year 2000, there was less than 300 papers, and in 2017, we had more than 3,000 papers in this field, which was great. And I'm briefly reviewed 20 studies, which I thought those are the most important studies published last year. We had two important randomized clinical trials. One is the Stampede trial from the Cleveland Clinic. Our group randomized 150 patients to sleeve gastrectomy, one-way gastric bypass, and intensive medical therapy. And the primary endpoint was hemoglobin A1C under 6%. And we published 1 year and 3 year data. And in 2017, we published the 5-year data, which showed that both procedures were superior to both surgical procedures are superior to intensive medical therapy in achieving the primary endpoint of the study. There was significant improvement in diabetes medications, lipid profile, and quality of life after the surgery. And as you see in the graph, if we compare both surgical procedures together, gastric bypass was associated with better weight loss compared to the sleeve gastrectomy. And in the upper graph, while both procedures, gastric bypass and sleeve gastrectomy, significantly improved glycemic control at 5-year mark, gastric bypass was associated with greater reduction in number of diabetes medication compared to the sleeve gastrectomy. The second randomized clinical trial, which was came out in November, was from Brazil, and that was the Gateway trial. That was the first trial in our field with primary endpoint on the blood pressure control. The investigators included patients with BMI of between 30 and 40 who were on two or more hypertensive medications at the time of the randomization, and they randomized 100 patients to two groups: surgical group, which was gastric bypass plus medical therapy, versus the medical therapy. And they followed the patient up to 12 months after the randomization. The primary endpoint was at least 30% reduction in number of antihypertensive medication while maintaining the blood pressure. And as you see in the graph here, in the gastric bypass group, almost 84% of patients met the primary endpoint by the end of the study, versus only 12% on the medical arm, which was statistically significant. And here, as you see, at 12 months after surgery, of the 49 patients who were on at least 2 hypertensive medication, 25 of them were off any hypertensive medication while maintaining blood pressure. So this study was published in the Journal of Circulation. We had so many observational studies last year, retrospective and prospective studies, which showed durability of the bariatric surgery in terms of the weight control and metabolic benefits. I selected 2 important studies for this section. One is the famous Ted Adams study from Utah. They had published their cohort report before, and last year they published the 12-year outcomes. And as you know, on this Utah study, in the state of Utah in the United States, 418 gastric bypass patients were compared to 2 control groups. The one control group was seeking for bariatric surgery, but they didn't get surgery mainly because of the insurance denial. And the second control group included patients who were not interested in bariatric surgery. And you see in the graph that it shows the weight loss trajectory of the gastric bypasses and the control group 1 and control group 2. So this study clearly shows the durability of the weight loss and the effect of surgery on diabetes remission and prevention. Also the effects on clear effects on hypertension and dyslipidemia after the gastric bypass. And the second study on this section is the follow-up outcomes of the lab trial, longitudinal assessment of bariatric surgery study. Labs come from 10 hospitals in the US. The patient had surgery, gastric bypass, or gastric banding between 2006 and 2009. And as you see here, the weight loss was pretty stable over the time. The mean weight loss at 7 years after the gastric bypass was 28%. And as you see, between 3-year mark and 7-year mark, there was only 4% increase in weight loss. So there was some modest weight gain after 3 years, but majority of patients could keep their weight off. And interestingly, in the band group, out of 610 patients in the band group, 160 of them needed reoperation for complication or for conversion to the other procedures. So we had many studies which showed health and survival benefits of bariatric surgery, and these are the end outcomes of these procedures that we daily do, because we want to improve the survival of the patient eventually, and we want to decrease the hard endpoints of cardiovascular events. So I selected 5 studies for this section. The first one is the post hoc analysis of the SOS study. This study was published in the Lancet Diabetes and Endocrinology, reanalysis of the SOS subjects. As you see here, the upper graph shows the cumulative incidence of microvascular disease in patients who had prediabetes at baseline, and the lower graph shows the cumulative incidence of microvascular disease after bariatric surgery in patients who had diabetes at the baseline over the follow-up of 20 years. And the study clearly showed that the surgery was associated with reduced risk of microvascular complications in patients with prediabetes and diabetes over the course of 20 years after the surgery. The next study on this section is about the weight loss and heart failure. The study came from the 2 large European registries, from Swedish and Scandinavian bariatric surgery registry. More than 25,000 gastric bypass patients were compared to almost 14,000 lifestyle modification. And as you see here, during a median follow-up of 4 years, gastric bypass patient had lower heart failure incidence than non-surgery patient, and it was statistically significant. We had 2 important studies from a Geisinger group in the United States. The first one is about the mortality reduction after the procedures. So these patients had surgery, had gastric bypass between 2004 and 2015, and more than 3,000 patients were involved in this study. As you see, in patients with diabetes, almost 650 patients had diabetes at the baseline. And as you see in graph, at the median follow-up of 8 years, we see a significant reduction in mortality in the gastric bypass patient compared to a control group who didn't have surgery. And if we look into the specific causes of the mortality, as you see in patients with diabetes, total mortality reduced, as I show you here in this graph, cardiovascular mortality reduced, respiratory, pulmonary associated mortality, and diabetes associated mortality significantly less in gastric bypass patients. And in patients without diabetes, cancer related mortality and respiratory mortality were significantly less in gastric bypass patients compared to the control group, non-surgical group. However, total external and external intentional, like suicide, were significantly higher in the gastric bypass patients in long-term run compared to the non-surgical control groups. And the second study from Geisinger again, it showed the impact of the gastric bypass on the severe cardiovascular disease. They define severe cardiovascular disease as incidence of MI, heart failure, or stroke. And as you see again, after 8 years, gastric bypass significantly decreased the risk of severe cardiovascular disease. And the last study in this section is about the protective effect of the surgery on the cancer incidence. Dan Schauber and David Arterburn published this nice study in Annals of Surgery last year. The data came from 5 centers in the United States. All these patients had surgery between 2005 and 2012, and they followed the patient with a mean of 3 to 3.5 years. And as you see, the surgery group had significant reduction in cancer incidence compared to the non-surgical group, and specifically the risk of colon cancer, risk of endometrial cancer, pancreas cancer, and postmenopausal breast cancer were significantly less after bariatric surgery compared to the non-surgical groups. Surgery in adolescents and teens. So I think 2017 was a unique year for this field. We had many studies on this field, and I selected 2 of them for this short presentation. The first one was published in the Lancet Diabetes and Endocrinology, a follow-up study of FABs plus 5, and these patients, 58 patients, had the age of between 13 to 21 at baseline, and under gastric bypass between 2001 and 2007, and with the average mean follow-up between 5 to 12 years. As you see in this graph, the long-term weight loss, the mean weight loss was 50 kilograms, which was significant, which was pretty remarkable, with the average BMI reduction of 17 points. And the investigators observed significant improvement in diabetes, hypertension, and hyperlipidemia in these kids. And the second study, again published in the Lancet Diabetes and Endocrinology, the follow-up data of the AMOS study, adolescents with severe obesity. All these patients underwent gastric bypass between 2006 and 2009, 81 patients with mean follow-up of 5 years. Again, long-term weight loss, mean weight loss of 37 kilograms with BMI reduction of 13 points. Again, the study shows significant improvement in metabolic profile of these patients. Interestingly, of those 81 patients, 20 of them, almost 25%, require reoperation for complications associated with gastric bypass. So of those 81 patients you see in this table, 11 patients needed reoperation, laparoscopy for a small bowel obstruction, and most of them had internal hernia. And 9 patients required cholecystectomy for a gallstone. And in the discussion part of the article, authors mentioned that they're not routinely close the mesenteric defects, Peterson or Zudo-Peterson defects during the surgery, and that's why they had this high incidence of internal hernia, and they hadn't give the patients the ursodeoxycholic acid to prevent the gallstone. That was not part of their routine practice at that time, and that's why they saw high number of gallstone and gallstone related disease in these kids. So that the lesson would be that in growing kids, closure of the mesenteric defects and prevention of the gallstone could be very important, and could be very critical, that potentially can prevent some surgical intervention in future. So the next section is sleeve versus bypass, the hot topic in our field. We had two important randomized clinical trials published last year. First one published in Annals of Surgery, the follow-up of SM BOSS trial, Swiss multi-center bypass for sleeve study. The investigators published 1 year data before, and now we have 3-year data. Briefly, 110 patients with gastric bypass versus 107 sleeve patients, and at 1 year, both all outcomes were comparable. And again, at 3 years, the investigators showed that both procedures result in comparable weight loss, quality of life, and complications up to 3 years after the surgery. The only complication which was significantly higher after sleeve was worsening of reflux disease. About 19% of patients in the sleeve group had worsening of the reflux compared to 2 or 3% in the gastric bypass group. And the second trial from IRCAD in France, smaller trial, 45 patients with bypass and 55 patients with the sleeve, 100 patients in total. This is published in British Journal of Surgery last year. The quality of life was comparable between two groups by the 5 years after the surgery. However, gastric bypass was associated with better weight loss, and we see this difference after the 2 years. So by the first year and 2 years, the excess weight loss was comparable between the two procedures, but after that, beyond that, we saw some weight regain in the sleeve gastrectomy patients. So weight loss overall at the 5-year mark was significantly better after the bypass compared to the sleeve gastrectomy. However, bypass was associated with higher readmission and higher complication rate, 47% readmission rate after the bypass compared to 18%, only 18% after the sleeve gastrectomy. And the last section of my talk would be practice changing studies. So I thought these 7 studies may have some impact in our daily practices. The first study on this section was published in Annals of Surgery. Is administrative data on more than 53,000 patients and in France, and it shows that it shows the long-term natural history of the gastric banding. And as you see here, by 7 years after the surgery, only 60% of the bands are still in place, and 40% of the gastric bands had been removed. And the authors concluded that with the 40% removal rate in 7 years after placement, and the need for revisional surgery for more than 2/3 of patients after removal, gastric banding does not appear to provide a long-term solution for obesity. And that's why we see less and less band placement in practice these days. The next study for this section, again, is published in Annals of Surgery. For the conversion of the band to other procedures, we're always worried about conversion of the band to sleeve because of higher risk of leak and early complication, and that's why the preference was to convert the band to bypass in many centers. So this study, the data came from the MBSA QIP data set. Is just about the safety 30-day outcome, not about the long-term follow-up. The authors compared more than 1,300 band to sleeve patients to more than 1,300 band to bypass patients. Both groups were matched based on almost 10 baseline variables. And as you see here, the leak rate was comparable, and the band to sleeve patient had less bleeding complication, less readmission, and less reoperation rate. And so they concluded that the conversion of the band to sleeve would be very safe, or even safer than conversion of the band to bypass. It's not about the long-term efficacy, it's just about the short-term safety of the procedures. The other study, which was published again in Annals of Surgery last year, is about the extended prophylaxis after bariatric surgery. Who should get extended thrombus prophylaxis after the surgery? We know that the VT is the main cause of death in our patients, and as you see here, most of the VT events occur after the hospital is discharged. If the average, the mean length of stay, if we consider as 1 or 2 days, as you see, most of the VT events, almost 85% of them, occurred after the hospital discharge. And on this study, we could identify 10 independent risk factors for the post-discharge VT events, which can predict the post-discharge VT events. And we made a risk calculator and an app which is available and which can be used in clinical practice. And the other study, which was published again last year in Annals of Surgery, is the Individualized Metabolic Surgery Score, or IMS score, which can help procedure selection based on diabetes severity. So the main question in our field is to choose between two main procedures, gastric bypass or a sleeve. So this IMS score is based on 4 independent predictors of long-term diabetes remission: pre-op number of diabetes medication, pre-op insulin use, pre-op duration of diabetes, and glycemic control. And based on this scoring model, patient can be categorized to 3 stages of diabetes severity, and the procedure selection can be done based on the severity of diabetes and based on the number of the based on the score on this scale. Again, this model and this calculator is available at this app, Bariatric Calc, which is available on App Store and Google Play. The next study on this section is about the timing between the bariatric surgery and birth and pregnancy. So this study is a population cohort study of patients who had bariatric surgery between 1980 and 2030 in hospital in the state of Washington in the United States. And as you see here, if the operation to birth interval is less than 2 years, we see higher incidence of prematurity and higher incidence of NICU admission compared to birth and deliveries in which the interval was 2 to 4 years. So the study concluded that operation to birth interval of less than 2 years can be associated with negative outcomes on the newborns. The other study for this section is how to manage the marginal ulceration. You know that about 5–10% of patients long-term after gastric bypass may get the marginal ulcer. And if the patient get the marginal ulcer, sometimes it's hard to treat that. It may bleed, it may perforate. So that's a retrospective study, but it was published in a high-impact medical journal. The impact factor of clinical gastroenterology and pathology is almost 8, so it's a very good journal. And this graph clearly shows that if we open the capsule, the PPI capsule, and we give the patient, ask the patient to use the open capsule instead of intact capsule, then that significantly decreased the time to ulcer resolution. As you see here, that's the time to ulcer resolution in the closed capsule, intact capsule versus the open capsule. And the multivariate analysis clearly shows that the only factor which can impact on the time to ulcer resolution is using the open capsule. If history of smoking, NSAID use, H. pylori infection, finding of foreign body, suture staple in the anastomotic, none of them had any impact on time to ulcer resolution. We usually prescribe sucralfate, carfate in our practice to manage the marginal ulceration, but it didn't have any effect on the time to ulcer resolution. The only significant factor was using the open capsule, not the intact capsule. And the last study on my talk is about the post-bariatric surgery, post-gastric bypass hypoglycemia. We see more and more these patients, which many of them have neuroglycopenic symptoms, which can be very debilitating. So these particular complication usually occur 1, 2, or years after the gastric bypass, and many of these patients had exaggerated insulin response, which caused severe hypoglycemia. And this is a small study which was published in Diabetologia, which is a high impact diabetes journal. It's only on 8 patients. It's a double-blind crossover study. They did oral glucose tolerance test with and without GLP-1 receptor blockage in patients who had typical presentation of this disease, and the study clearly showed that GLP-1 receptor blockade prevented hypoglycemia in 100% of individual lives. It normalized beta cell function and reversed neuroglycopenic symptoms, which can support the conclusion that GLP-1 plays a primary role in mediating hyperinsulinemic hypoglycemia in patients with post-bariatric surgery hypoglycemia. So that would be a novel finding, and that can show us that if we use GLP-1 receptor blockade, that may have good impact on these patients who had this debilitating disease. Okay, so thank you, everyone. It was just a brief description of 20 studies, and forgive me if I miss any important studies. Thank you again.